Hi, my name is Michael, and today we'll be talking about epistaxis, or nosebleeds. We'll go through the clinically relevant anatomy, the risk factors behind nosebleeds, how to assess and manage patients with nosebleeds, and when to escalate to seniors. We'll talk about the common equipment, and we'll try and go through them to familiarize yourself with them. So in this case, you are sort of an ED, F1 or F2. You've been asked to see a 65-year-old lady, Jane, who presents with waking up with blood all over her pillow at 4 a.m. You notice a continuous ooze over her left nostril, and she's alert, she's able to give a history. So I want you to take a moment just to think about what questions you might ask her. You can try and use a Socrates approach, so just taking out the things that may not be relevant in this case. So in terms of S, so sight is very important to try and think about where the bleeding point might be, and that really changes management down the line. Which we'll come on to. So, which side did you first notice the nose bleeding was coming from? Was it one side? Was it both sides, or was it sort of down the back of the throat that you noticed bleeding was occurring first? So, if it's sort of one side, it makes you think more of an um, anterior bleed or anterior epistaxis. But if it was maybe down both sides or down the back of the throat, that makes you think more of a posterior site of bleeding. So when did it start? How many episodes have you had? How long was each episode? And how much blood do you think you've lost in sort of teaspoons or cups? These all might help you decide sort of the severity of the nosebleeds, sort of the urgency of bloods, and whether you think they might need a blood transfusion. Helpful to know what might have caused the bleeding. So, are they particularly prone to sort of changes in weather? Do they get that? Do they get nosebleeds in those situations? Or have they had any sort of major or minor trauma to the nose, or blowing their nose or picking at their nose? It's also good to sort of ask about other associated symptoms. So, have they had sort of facial pain, otalgia? These might point more towards a sort of a malignancy as well, a nasopharyngeal malignancy, but these are much rarer. Do they have any sort of bleeding elsewhere? So, PR bleeding or sort of menorrhagia that might indicate maybe a coagulopathy. And how are they sort of systemically? It's good to ask about past medical history to find out any other causes of the bleeding, whether they've been on sort of anticoagulation, whether they've had any sort of nasal sprays that can often have steroids in them and cause thinning of the mucosa and bleeding. Asking about sort of family history of bleeding disorders and any sort of social history, as sort of cocaine can cause nosebleeds too. And these are some of the risk factors that might cause nosebleeds. So you have sort of non-traumatic causes. Aging and thinning of the nasal mucosa is very common. And sort of changes in the weather and drying of the mucosa can cause nosebleeds too. So Jane said that she woke up with bleeding and came straight to ED. She noticed it came out of her left nostril, and she noticed about maybe 50 mils of blood, to maybe a few sort of teaspoons of blood with some clots. She admits to having really bad hay fever, and she's blowing her nose a lot recently. How would you manage this patient? So all patients who come into the emergency department will most likely have bloods, routine bloods, so a full blood count, Usinese, clotting, and you might also want to consider a group and save if you are thinking about possibly transfusing her in the future. Life-threatening epistaxis, so when patients are unstable, very unwell, and you might consider doing an A2E approach, or you would do an A2E approach and gain IV access as well. You would call for senior help early on, and if you're very worried, you might even activate a major hemorrhage protocol. It's important to note that with management, you're often having to take a history, examine the patient, and also start management all at the same time. So although we've presented it in a sort of very linear fashion, it might not be the case in real life. The first line for any sort of nosebleed would be a first aid approach. And the reason for this is because before you start packing patients with to stop the bleeding, you want to try the least invasive and most comfortable approach. So you'd get the patient to sit up with their head forwards over a bowl or sink, and you get them to pinch the fleshy part of their nose, so not the nasal bone, but just below that, and you get them to lean forwards. You get them to do this for 15 to 20 minutes, maybe with some cold towels on their forehead or ice blocks on their forehead or in their mouth to aid sort of vasoconstriction of those bleeding vessels. And you get them to spit out any sort of blood, as that can cause vomiting as well. After sort of 15 to 20 minutes, if that's stopped, then that's great. But if not, you would want to further examine the septum with fediculum speculum. You'd want to first suction the area, remove any sort of blood clots, and usually you'd give sort of you'd soak cotton wool in adrenaline, or use a cofenarchine spray to apply to the area and to reduce the amount of bleeding and vasoconstrict those vessels as well. That will help you with your examination down the line. So, as you can see on the right, that's the speculum, and you can see a plexus of blood vessels on the medial aspect of the septum. The most common area to cause bleeding is called Little's area, or the Keisel plexus, as you see on the left-hand side. This is made up of multiple different arteries that supply the anterior aspect of the septum. In 90% of the cases, this is the area that is the bleeding point. In 10% of the cases, it's caused by a posterior bleed. If you can see a bleeding point, you want to apply direct therapy. So that's either cauterization with a silver nitrate stick or application of hemostatic matrix. Once you've applied that and it stops the bleeding, you might want to give them an aseptic cream to apply for 2 weeks post-cautery to aid healing. It does, however, contain peanut oil, so you should not give this to people with nut allergies. And you should avoid cauterizing both sides, as that can lead to septal perforation due to the ischemia that you're causing by cauterizing the septum. If that fails, then you would consider, as a third line, nasal packing. So there are 2 bits of equipment that are commonly used. So you've got Mericel, which is a nasal tampon, but you've also got rapid rhinos as well, which is a nasal tampon with a balloon on the end. With both of these, you apply it and you insert it along the base of the nasal cavity rather than aiming up towards the brain. And with the rapid rhinos, you would soak them for 30 seconds in sterile water, insert them, and inflate the balloon, securing the end to the face. You might sometimes need to pack bilaterally, but you need to consider sort of the cardiorespiratory comorbidities, and some patients with COPD, for example, might need supplementary oxygen. If, however, anterior nasal pack is unsuccessful, or there's a posterior bleed that you're worried about from examination or from the history, you will need to use either a Foley catheter, a 14-gauge Foley catheter, which is inserted into the nose, and the balloon is blown up as you would for a urinary catheter, and you would pull this until it reaches resistance. You would then pack anteriorly with gauze as well. Alternatively, you have rapid rhinos, which have both a posterior and an anterior balloon. But it's best to sort of familiarize yourself when you're on placement with these different bits of equipment. And if there's ongoing bleeding despite effective packing, you would alert your registrar and your seniors early. It may be the case that they might need a surgical arrest of the hemorrhage, and that involves ligating commonly first the sphenopalatine artery. If you're thinking that these patients are going to go to theatre, the plan should be to keep them nil by mouth. You might also give IV fluids, and you get wide bore IV access. The pack should remain in to act as a way to apply pressure and try to reduce the bleeding. And you'd also get a full set of bloods, including a group and save as well.